Okay, welcome. Can everyone kind of give me a hand signal if you can hear me, if everything's working okay? Terrific. That's what I love to hear. Great. I have, for the moment, just in the interest of keeping this running smoothly, we're going to go ahead. I have the ability as the host here to mute the microphone lines, but then at the conclusion of the presentation, I'll go ahead and unmute everyone for questions and discussion, if that makes sense. Can everyone see the presentation that I have on their screen? We're looking good? Great. Okay. Well, again, thank you for joining me this evening. I really appreciate it. I know it's a little bit late here on the East Coast, but we're trying to accommodate everyone from coast to coast. I'm going to talk about a topic that I'm very passionate about, and it's the early detection of coronary artery disease, and specifically some new technology that's out that may be in your own backyard that you may not be aware of, that it even exists and can save your life and prevent you and your loved ones from ever having that first heart attack to begin with. And I hope that you're going to pick up a lot from this presentation. I've done this presentation for patients all across the United States, and this is my first time on a webinar base doing this, but I'm sure it's going to be successful. You see here. There we go. Okay, a little bit about my background. I'm a cardiovascular physiologist, a preventive cardiologist, went to medical school at USC. I also have a PhD in public health from the USC School of Public Health. I was with a large cardiology practice in Columbia, South Carolina, the South Carolina Heart Center for about 10 years, and I'm really focused on imaging of the heart and early detection of heart disease, really believing that if we wait for patients to have that first heart attack and come to the emergency room, it's too late and we've failed. We really have an opportunity now using new technologies that I'm going to talk about to get out in front and find patients who are in their 40s, in their 50s with risk factors for heart disease, and find out who's at risk of having that heart attack non-invasively at a very low cost, and prevent them from ever having that first heart attack in the first place. And that's a very unique opportunity for patients and clinicians alike. And I really think that it's just making a huge difference across the United States. We've personally, with my group, scanned over 200,000 patients already, and we've saved countless lives by detecting this disease before the patients had the heart attack. I'm going to talk specifically about a test that you may or may not have heard of. It's called coronary calcium scoring, or coronary artery scoring. This is a test that's in 99% of hospitals across the United States. It's probably within driving range of each of you. The problem is many patients don't realize this test even exists, or that it may be in their own backyard. And to make matters worse, their physicians, their own primary care doctors, may not be aware that this test is available to their patients. So a very unique opportunity. The test itself, just to summarize, is a very, very simple, most patient-friendly test I've ever been a part of. It's literally a 5-minute test. There's no needles, no contrast, there's no patient prep, no patient recovery. You can see in the image, it's done in the CAT scan machine that all hospitals have. It's a very open machine. There's 3 EKG electrodes just with suction cups so we can get a heart rate, so that we can get a nice pretty image of your heart. The patient lays down on the table scanner, as you can see in the image. They slide the patient into the scanner, and it's 1 breath hold. In less than 30 seconds, we can scan using new software in this CAT scan machine and look at your heart, and specifically at the coronary arteries that become blocked, causing heart attacks. We can see those blockages now from outside of the body in less than a minute's time. And it's life-saving technology. Like I said, it's available in the majority of hospitals in the United States, and it truly changes the entire paradigm of cardiovascular disease in America. But let's get to why this is important. How does this test make a difference? How does it prevent heart disease and heart attacks specifically? The unfortunate statistic still in 2016 is that 50% of Americans find out that they have coronary artery disease or heart disease by having either a heart attack or sudden death. Those are unacceptable statistics. Again, we have this technology that in 5 minutes or less can tell us if we're one of those people that is at risk of one of these events. If we could only get those patients that have the risk factors for heart disease into the scanner to get them tested before that event, we can prevent it from ever occurring. So ultimately what we're trying to do as a cardiology community is trying to get out and educate patients such as yourselves, and get out and educate other physicians and hospitals on how to use this technology, how to relay this information to family, friends, coworkers, that this technology exists, it's out there, it saves lives. And we really want you to start thinking about heart disease as a test, and heart disease as a disease that can be prevented, much like mammography and breast cancer. So we don't have to talk in depth about the statistics of heart disease. We all are very familiar. We know heart disease is the #1 killer in America. It is an interesting statistic, I think, that almost 40% of heart attack victims don't survive that first event. So again, if we just wait for our risk factors and our age to catch up with us, and we become one of those 50% that have that first heart attack by waiting for the first event, 40% don't survive that first event, as good as cardiology and medicine has gotten. So we really, again, we owe it to ourselves and our family and our friends to share this information, let them know this test is out there. It can save their life if we only know who has the blockages before the first event. I really want to highlight bullet point number 3, though, that coronary artery disease is the #1 killer of women, more than the next 7 causes of death combined, including breast cancer. So, while the breast cancer awareness folks do a tremendous job of raising awareness, of motivating females to go out and get their mammograms, which is very, very important, if we really want to impact mortality rates among females in the United States, we would hear a lot more promotion and education and marketing campaigns toward the education of heart disease in women. It's a very serious disease for females, kills just as many females every year as males. And in fact, women, once having that first heart attack, are less likely to survive the first event than their male counterparts. So again, calcium scoring, a very important test for the female population. Again, non-invasive. And just so you know, the cost of this test is relatively low. It's about a $99 test. I always told patients it was about the price of a nice dinner for 2 to find out if you're at risk of sudden cardiac death. I think myself that it's quite affordable. We can go to the next slide. So let's talk a little bit about what your primary care, what your current doctor is already doing about your cardiovascular health, and how he or she may be estimating or gauging your risk of having a heart attack. The Framingham Risk Index is what's in place in the United States. And it's been around since the 1950s. And what Framingham does is it takes your risk factors for heart attacks, like high blood pressure, high cholesterol, obesity, smoking, etc., and combines them with the patient's age, and then places them into one of 4 risk categories, from very low risk of having a heart attack to very high risk of having a heart attack. That's what most primary care physicians in the United States are relying upon. Now, the Framingham Risk Index is very good at identifying people at very low risk for a heart attack and at very high risk. But that large population, about 2/3 of the American adult population, falls into what we call intermediate risk, that middle ground. And for the intermediate risk population, Framingham has weaknesses, and it tends to misclassify patients. And that's why the majority of heart attacks come from this intermediate risk population. We know scientifically that for this intermediate risk population, which by the way is who's indicated to have a calcium score, if you're intermediate risk, we know that this test provides huge additional value for that patient population and allows us to more accurately diagnose your level of heart disease or the absence thereof. So it really is a very important test for that population. This is a very, very low radiation dose, very patient-friendly, patient-safe test. The basic premise, I like to include this, if tests for coronary artery disease like calcium scoring had been around at the beginning of the prevention era, that would be the gold standard rather than risk factors. This test for the first time allows your doctor to move beyond risk factors, managing you based on your blood pressure, on your weight, on your cholesterol level, whether you have diabetes or not. For the first time, now he or she can look directly at your heart itself, look specifically for blockages in the coronary arteries. If your coronary arteries are absolutely clean, we know that you're at very exceptionally low risk of having a heart attack. If you have major blockages, they're going to show up very readily. And now we can medically manage you appropriate to your disease level versus guessing based on risk factors. So it really changes everything in how patients are managed. One of the things that's being done on a regular basis and is a very good test is stress testing. However, stress testing is maybe not the best test for predicting who's likely to have a heart attack. It's a great test at looking at blood flow through the heart. And Tim Russert's story, of course, was a national news anchor about 6 or 7 years ago, died of a heart attack while preparing for the evening news at his anchor desk. He had just been within a month or two of having an executive physical. He had a cardiologist give him a stress test, gave him a clean bill of health. Yet a month later, died of a heart attack at his news desk. This story is not uncommon. A University of Michigan study showed that almost 6 out of 10 heart attack patients were within 1 year of having a normal stress test. So just because a patient has a clean stress test doesn't necessarily rule out their risk of having a heart attack or dying from coronary artery disease. Very important to be clear on that. The second thing I want to talk about that your doctor has probably talked to you about is cholesterol level. And certainly keeping your cholesterol in check is very important. I'm not downplaying the value of that at all. However, as this big study shows us, out of 137,000 patients, all in the hospital with heart disease, almost 8 out of 10 had normal cholesterol levels. So just because a patient's cholesterol is controlled or down in a normal range, it does not rule out their risk of having a heart attack necessarily. So we really have to be clear on that. So clearly what we're doing is not enough. If 50% of Americans find out they have heart disease by having a heart attack or dying as the first symptom, that's just unacceptable. We have a test for $99 that non-invasively in 5 minutes or less tells us if we're going to be that next victim or not, and allows us the unique opportunity to do something about this disease before you become a victim. We can go to the next slide. This is a case study that will kind of illustrate, predicting risk of a heart attack based on our common perception of who's most likely. And these are two well-known men. Both were smokers, both were overweight and inactive. One completely changed his ways. He became a physical fitness fanatic, lost his weight, did everything right. The other remained very inactive, remained obese. Both of them had a family history for heart disease. So on the next slide, we can see who was at greater risk for the development of heart disease. And we have on your left, Jim Fixx, who back in the 1970s was the poster child. He was on the President's Council for Physical Fitness. He was a marathon runner, did everything right, lost all of his weight, yet died of a heart attack quite suddenly at age 53. He was intermediate risk at the time of his death. Now on the right, you see Winston Churchill, who broke every rule of healthcare ever written, yet led a relatively healthy life all the way to the age of 91. So again, it just illustrates to us our inability, if you will, to predict who's at greater risk of a heart attack. Anyone who saw these two individuals would guess that Churchill would have been the heart attack candidate, but in fact, it was Jim Fixx. That's what this test allows us to do. Had we had the ability to place both of these gentlemen in the scanner and look at their arteries, we would have observed quite quickly that Jim Fixx was on his way to a major heart attack, and we could have prevented that from occurring. Let's talk just for 2 minutes about the science. I just want to reiterate to you that this is a very scientifically validated test. This is not a typical screening test by any means. This is a diagnostic test that's in all the hospitals across the United States. The utilization is going up significantly. The American College of Cardiology and American Heart Association have both endorsed this test, recommended this test for intermediate risk patients, as I've said. In fact, their statement is that calcium scoring is the most useful approach to improving the assessment of intermediate risk patients. So that's their gold stamp of approval. This test is by no means not reviewed. It's endorsed. It's supported by all the guidelines and all the societies. If we go to the next slide, these are the appropriateness criteria. The SHAPE societies, the Society for Heart Attack Prevention and Eradication, they wrote the guidelines. I'm on the board of SHAPE. We actually wrote the guidelines for which patients are best served by having this test. And quite simply, it's males 45 and older should have this test, females 55 and older should have this test, and younger adults with 2 or more risk factors for heart disease, again, high blood pressure, high cholesterol, obesity, diabetes, family history, smoking, 2 or more of those, classifying them as intermediate risk, then those patients should have a coronary calcium score per the guidelines. To give you an idea of what the outcomes of a calcium score test look like, what do the results mean? A negative test is a 0 score. For a patient that has a 0 score, they have an exceptionally low risk of having a heart attack. Positive scores are 1 and above. Now, there's a very early score category. 1 through 99 is very early coronary artery disease. Really, the blockages are too early to really cause any type of health-related problems. But it affords us the opportunity to find out that you have that early stage disease. I always use the analogy of, think of the bathroom sink, your drain in your bathroom sink, and of how blockages occur. When there's initially some film in the drain of your sink, the water's still flowing rapidly. You don't even notice anything's wrong until you take the sink apart and you look and you see that there's some buildup starting. That's what this early stage disease is. Your blood is still flowing through your arteries. There's no problem, but undetected and unchanged, it's going to continue like your bathroom sink to build up, get worse until eventually it blocks, and now we have a problem. The second stage of positive tests are 100 to 399. This is kind of your high risk category. There are some blockages here. There are blockages. They may be severe. Most likely they're still early enough that your doctor can medically manage you with exercise therapy, weight loss, behavioral change, modifying those risk factors, perhaps statin therapy, which is a pharmaceutical for lowering your cholesterol. Those are options to try to stop the progression of this disease if we detect it early. The third category for calcium scores are 400 and above. This is where you have likely severe blockages. The patient at this point needs to see the cardiologist. These patients are more likely to have a heart attack or have sudden cardiac death and really need follow-up testing. So again, those are kind of the outcomes, just as an overview. Let me go back for 1 second and just reiterate. Of the intermediate patient population, about 40% of the patients, 45 and older for men, 55 and older for women, will have a 0 score, a clean bill of health. About 60% will have some level of disease. However, the good news is the vast majority of them, about 70% of the people identified with disease, have that very early stage disease, 1 through 99, where it's a very unique opportunity to stop the plaque from getting worse, and the patient will never have the heart attack. So again, that's that good news. Only about 15% of the patients will have severe disease, but for those patients, this is life-saving technology. I'm going to show you 2 research slides just because I think they're important and they really show the power of this test and why it's important to have this test. The first one is from New England Journal of Medicine and looked at major coronary events over time for patients having a calcium score. And you can see on that graph that as the patient's calcium score went up, so did their major coronary events, as we would predict. You can see there's a nice difference between each of the levels of calcium in the coronary arteries, the blockages, and the events that they're going to have as time progresses. The key to this slide and of this study are the 0 scores. If you remember, I said a patient that has a 0 score is at exceptionally low risk of having a heart attack. In fact, a patient that has a 0 coronary calcium score has less than 0.5% chance of having a heart attack over the next 5 years. So probably about as close to a guarantee as you're ever going to get in medicine. So a very strong, what we call a negative predictive value, the ability to rule out your chances of having a heart attack or dying from coronary disease. The next one is a very interesting study and was very important, and it really shows you the weakness of the Framingham Risk Index. And again, that's what your primary care doctors across America are using and relying upon to judge your risk of having a heart attack. This particular study took over 3,500 patients. All were intermediate risk. All were given a calcium score to determine how many of these patients labeled as intermediate risk really would be high risk if we could look at their heart, if we could look at their arteries. And what they found was that over 60% of these patients were truly high risk once we looked at their coronary arteries and saw blockages. And now conversely, 25% were able to be moved down into low risk because they had a 0 score. So in total, 86% of these patients labeled as intermediate risk really were labeled incorrectly and were reclassified after having a calcium score, allowing them to be managed specifically for their disease level or the absence thereof, and getting better medical care as a result. A quick case study to kind of wrap this up. A very, very typical patient, 47-year-old female in her primary care office, concerned about her family history. Both mom and dad had coronary artery disease. She's concerned about her risk for a heart attack. Her clinical background is she has slightly elevated cholesterol. Her physical is normal, and she's asymptomatic. She has no symptoms or signs of heart disease at this point. So, given that information, the typical primary care physician in the United States today would provide reassurance and send her out the door. Using Framingham alone, the risk index, her risk of having a heart attack or dying from coronary artery disease is exceptionally low. In fact, it's less than 1 in 100. So we would send her out the door. This doctor had access to a calcium score, set this patient for a calcium score, and we'll be able to see here that her score was actually 106, which placed her in that that high risk category, that middle category. Of course, her outcome changed from send her out the door, reassuring her that she's healthy, to a much more aggressive medical management strategy. Again, trying to stop that plaque, stop the disease from getting worse. And what's interesting, and you'll actually be able to see here on your screen, her heart images, you can see those white nodules. Those are her coronary arteries. That's the calcium score image of her heart. And all those white blobs that you're seeing are actually plaque. Those are blockages in her coronary arteries that cause heart attacks. The key to this study, beyond being able to see the disease itself, is that, remember, by Framingham alone, her doctor would have sent her out the door telling her she had less than 1 in 100 chance of dying or having a heart attack in the next 5 years. When in fact, now that we see these images, her risk of heart attack or death is actually greater than 1 in 5. So that's a tremendous difference for this individual patient. And I see patients like this all the time that come across my desk where Framingham placed them at intermediate or low to intermediate risk. But after we look at their heart, we're finding severe heart disease that would have led to a heart attack had they not had this scan. So again, who needs this test? Intermediate risk patients, males 45 and older, females 55 and older, younger adults that fall into that intermediate risk category, having multiple risk factors for coronary artery disease. These patients need to call their local hospital, talk to their primary care doctors, ask them how they get scheduled for a coronary artery calcium score. Let me click here. Just to show you a little bit, I told you that we've done over 200,000 patients. This is almost our first 100,000, and I presented this data at the American College of Cardiology this last year. You can see the 0 score About 41% of patients, as I shared with you, had no disease. 34% had that very early stage disease, and only 13% had scores of 400 or higher, again, where we're looking at very high risk. These patients have severe coronary disease. They go on to see the cardiologist, but their lives saved. The key is there's also an unwritten score in the world of calcium scoring, and that's the 1,000 or above score. This is kind of the uh-oh score. We know these patients have severe disease. They are the proverbial time bombs waiting, heart attack waiting to happen, if you will. We were very surprised by the number needed to diagnose or identify a patient with a score this high. In our first 82,000 cases, it was 1 out of every 29 patients that we scanned had a score of 1,000 or greater. These patients, for the most part, go on for stent or bypass surgery. While the number is still quite low, if you're one of those 29, these are truly lives saved. So this test really, it does make a difference clinically and helps avoid unnecessary death and heart attacks that just completely, honestly, don't need to occur in 2016 and beyond. So at this point, what I'm going to do is I'm going to open this up and unmute everyone and open it up. Everyone is unmuted at this point, and hopefully this will go smoothly. And I'm going to open it up for any questions or comments if anyone has anything.
Hello, Doctor. Hello.
Hello.
I had a heart attack in 2014 when I was 60. I now have a pacemaker defibrillator. Does your ejection fraction ever go back up?
It certainly can, and certainly that's the goal. And with your pacemaker, initially, I'm sure you saw your ejection fraction go up a little bit. And for the rest of you that don't know, ejection fraction is quite simply the percentage of blood that's pumped out of your heart with each beat, and it's a very important component of heart disease. But yes, absolutely, your ejection fraction can go back up with the combination of the right medicines, the right diet, right exercise, just generally getting healthier. Certainly, your pacemaker should help that. So absolutely, keep following your cardiologist's advice, and I'm sure you'll see your ejection fraction climb, hopefully in time.
Yes, it did. It went from 30 when I first got the heart attack to 39.
Terrific. Terrific. We want to see it go much higher. So keep doing the right thing and watching out and following your doctor's advice and obviously taking your meds.
Yes.
So
question for you, doctor. So
yes.
Why wouldn't it be necessary for doctors for you to have the coronary calcium score test rather than the Framingham test?
Well, and that's a great question. And as you can see here, on my question slide, it says National Heart Health Program. And I've actually left the practice I was with, and now I actually train cardiologists, doctors, and hospitals all around the world now, and put in this program specifically training doctors about coronary calcium scoring. And we've actually put our program into 100 different hospitals across 13 countries now and growing rapidly. So slowly that training is getting out there, but like anything else in the world, it moves much slower than we'd like it to. We really are working very hard on that. For the primary care doctors who are using the Framingham Risk Index, keep in mind, it's a very good test. It's a free test. So for everyone, for all of the patients that they see, it's still a very good entry point to the system. And what Framingham allows you to do as a primary care doctor is to go ahead and say, well, this individual is very low risk, so they don't need a calcium score. This patient's very high risk. They can just go on for a different test. But again, it's parceling out and identifying that intermediate risk population and then sending them for a calcium score. And that's what Framingham still is very good at and why we still want it to stay in place. But critical, though, is that training and education of doctors across the country about calcium scoring following Framingham. But it's all coming, and it's growing rapidly, but not fast enough.
Okay, thank you.
Certainly.
Hello?
Yes.
Hello? Can you
Hello.
hear me?
Yes, I can. Go ahead.
Where would I go to take the calcium assessment, and how often do you recommend that I take it?
Well, I'm glad you brought that up, specifically the second part of that test. Actually, most hospitals have the ability to do calcium scoring. You can call your local hospital or a local imaging center. If you're in a metropolitan area where there are imaging centers, many of them do calcium scoring as well. But the majority of hospitals will do that. And if your local hospital doesn't do that, you certainly could call your primary care provider, your physician, and they would be able to recommend someone to do the test. But the majority of hospitals do it. As far as how often you need to have the test, very good question. If you have a 0 score, as I showed in the presentation, you're suggested to have the test once every 5 years. If you have a positive score, you'll then be under a doctor's care, and at that point you follow your doctor's advice as to when to have a retest. Okay?
It would be up to the doctor?
Correct. If you're identified as having some coronary artery disease, if the test shows that you have blockages in your heart, he or she will then work with you, of course, to stop those blockages from getting worse. So at that point, it would be up to that doctor as to when they want to take you back and have a follow-up test.
Okay, thank you.
You're very welcome.
Another question. Would I need calcium screening? I'm not the one that had the heart attack.
No, and that's a good point as well. This test is really indicated for patients who have risk factors for heart disease, but not for people who have known heart disease. So in your case, because you've already had that first heart attack, you're under a cardiologist's care, they already know, they've already imaged your heart. It just wouldn't be necessary for you to have this particular test.
Okay.
Okay?
Thank you.
But certainly tell family about this test.
Yes, I will.
Because they certainly would.
Doctor, I have a follow-up
Yes.
question. The cardiac ablation testing, is that something similar to the calcium or the Framingham, or neither one?
Yeah, the cardiac ablation test procedure is more of a procedure dealing with the electrical system of the heart. And it has to do more with your heart rhythm and keeping your heartbeat steady and where we want it in a safe range. This has to do, I use, in fact, next Tuesday, rather, at 8:30, I'm going to be giving another presentation on heart disease and heart basics. And I'm really going to break it down. I'd encourage you to come on and see that. I break it down. I like to use the analogy of your heart is very similar to a house. You know, the electrical system is that rhythm. That's what cardiac ablation is all about, is getting that electrical impulse stable. What we're talking about is blockages, more like the plumbing in your house. And when those blockages occur, that's what leads to heart attacks. So 2 different systems, but all heart disease. But again, we'll be sharing much more about that next Tuesday at 8:30.
Okay, all right, thank you.
Absolutely. Oh, okay.
I have one more question.
Oh, go right ahead.
Yeah. I remember it said that the test was $99, but as a preventative measure, would it be covered under most HMOs, most insurance companies?
You know, that's an interesting question. You certainly would think that would be the case, but as is always the case in